You're doing a skin check on a 55-year-old, otherwise healthy guy when he points out an erythematous scaly plaque that's been on his right lower butt cheek, extending onto his thigh that's been there for over a year, he says, and it's itchy on occasion. You decide to do a KOH prep, since everything that scales should be scraped to rule out tinea. After scraping the lesion, you also do a quick, thorough lymph node exam, since mycosis fungoides is in the back of your mind, and clinically, lymph node involvement is very important for staging. The KOH comes back negative, but Dr. Grumpy Pants decides to treat the patient as tinea anyways, and he's going to have the patient follow up in 2 weeks. So you nod along, but in the back of your head, you have a feeling that this dude has MF. A biopsy will likely be done next if he doesn't improve with the ketoconazole. So let's say you're back in clinic with the man himself, Dr. Grumpy Pants. It's 2 weeks later, and that patient has returned that you thought had MF. He then asks you,
"If this is in fact patch stage MF, what then will the biopsy show?"
So you reply with your head held high that there will be a band-like infiltrate of atypical lymphocytes at the DEJ. There will be epidermotropism of these lymphocytes into the epidermis. It's not as much epidermotropism as you'd expect for plaque stage, but actually there is more epidermotropism in patch stage than what you see in tumor stage MF. In this patient, some of these atypical lymphs cluster into Poutrier's microabscesses in the epidermis, and you may also see papillary dermal fibrosis. If these histo findings aren't definitive, which they often aren't for patch stage MF, then T-cell rearrangement studies can be done to look for clonality, which is going to be suggestive of the diagnosis. So you're on the last day of your rotation and the patient comes back for biopsy results. And what do you know? It's patch stage MF and you were right. Grumpy Pants asks you,
"Well, since you're such an expert so far, what do we do next?"
Since you already listened to this podcast and did a little reading on your own, you tell him that patch and plaque stage MF without palpable lymphadenopathy does not need further staging workup, such as CT scans for lymph node involvement, lymph node biopsies, or any kind of lab work. So we can jump straight to treatment. Patch and plaque stage MF can be treated with skin-directed therapies, such as super potent topical steroids such as clobetasol, or topical nitrogen mustard, which is also known as mechlorethamine hydrochloride. These both lead to complete remissions approximately 60% of the time and are important adjuncts in advanced tumor stage MF as well.